Thank you for that introduction. Oh, sorry. Well, actually, I'm now a professor of mechanical engineering, and it looks like I was also promoted to director on this slide, so I'll take it. So yeah, it brings me great pleasure. I started this women's health project, this journey, when I was at MIT 20 years ago, because a maternal fetal medicine specialist at Tufts Medical Center right down the street, who had physics training, came across the Charles River to MIT, where I was a graduate student. I was 20 years old and said, I just delivered 24-week twins. And he wanted to understand why the uterine cervix opened too soon. I'm a mechanical engineer, MIT gal, and I tell this joke a lot to my students. I didn't know what my cervix was. I didn't think about pregnancy, but learning about its material properties, how it has to be a dual mechanical barrier in pregnancy, absolutely fascinated me on a structural level. I'm a structural engineer. I'm from Detroit. I worked at General Motors in the assembly plants. So it actually brings me great pleasure to have an audience of fellow engineers to talk about these women's health projects, because I think you're going to appreciate the physics that I'm about to show you, but you're going to also appreciate the application as well. So I'm going to talk about digital twins of human pregnancy, diagnosing and preventing preterm birth. The digital twin you see there, which is rendered in FE-Bio, is of the cervix. It's of a surgical procedure called a cerclage. Now, if a cervix is at risk for opening up too soon, causing the patient to go into preterm birth, the only clinical intervention they have is this surgical procedure. It was invented in 1950s. It hasn't been revised since. And any mechanicians in the audience will appreciate the amount of stress concentration. And I tell my engineering students, it's like taking dental floss and putting it around your pinky and pulling on tight. It also brings me great pleasure to be here in a room because we talked about fantastic innovation in other fields of medicine, and it blows me away. And again, yesterday the sentiment is we have the tools. It's about the problems that we choose to solve, and I teach this to my Columbia engineering students all the time. All right. So I have a few disclosures. I have industry-sponsored research from GE Healthcare. Dr. House's startup company has an NIH STTR through CX Therapeutics based here in Boston. I have generous funding from the NIH and the National Science Foundation, thank God. And also the families that we work with, the IRIS Fund, which is a lost family organization, and I can talk about the IRIS Fund. I'm actually doing an event for them tomorrow for the New York City Marathon, and the Blavatnik Family Foundation. Women's health, we heard a lot about it last year thanks to Jill Biden and President Biden. The first report there is the McKinsey report on closing the gap in women's health research. At Davos in 2024, they said it's a $1 trillion return on economic investment. That should just stop you right there. It's $1 trillion. That report covers the lifespan of a woman, okay, from puberty to gynecologic health, pregnancy health, or a lot of women don't get pregnant, up until aging, perimenopause, and menopause. Now that stuff's hitting the news right now. There's a lot of work in aging and menopause, ovarian aging. I can talk for days about the ovary and the uterus. I can't in the time given to me. Then we have reports from Digitalis Research in 2024. That National Academy of Medicine report just dropped last month. And then I was part of an NSF visioning event last year about transforming women's health through engineering. And that report from last year's Ohio State meeting should be coming out any day when the government opens. So the reproductive tract undergoes dramatic changes during pregnancy. I had to pull these slides back out to explain the uterus is an organ. It's about the size of a pear in non-pregnancy. And as you can see, in pregnancy, it has to grow and remodel and stretch. The cervix is the thick-walled cylinder at the end of the uterus, keeping the uterine walls together. The uterus can grow, it grows 15 times, has volume carrying capacity that grows up 500 times. It's really, really small, actually, the intrauterine space in non-pregnancy. And then it has to carry 2 liters of soda by the end of pregnancy. Again, this is when I tell my engineering students, I teach mostly men, so they don't know about these things. The cervix, uterus, placenta, the fetal membranes have these remarkable mechanical functions. The uterus is a giant muscular organ that has to not contract during the 39 weeks of pregnancy. Then there's something that triggers the uterus to say, hey, go into labor contractions, and they have to be strong, and that is mechanical. Those labor contractions can be signaled by hormones, of course, but they can also be signaled by uterine stretch. Now, the fetal membranes also have to remain closed and tight. And then it has to remarkably fracture and break. It is a fracture process. That's something we learn in mechanical engineering. And I also joke that we all can kind of think about, our water's breaking. I thought I was going to deliver in the New York City subway. I didn't, thankfully. But that is a rupture problem. What is the critical threshold that those membranes are going to break? There's a condition called preterm rupture of the fetal membranes, and that can put the baby and the mom at risk for ascending infection. And then there's the cervix, which is at the end of the uterus, which is what I model. I need to understand, how does that cervix remain closed? How much mechanical load is on the cervix? And then it has to remodel its material properties by over 3 orders of magnitude. So if I took a strip of uterus, I pulled on it, it's about 1 megapascals in tension for its Young's modulus, if you will. A pregnant cervix is about 1 to 10 kPa. So it has to remodel its biology that much to accommodate, if you will, and I said this yesterday, a watermelon squeezing through a kiwi. And it has to do that in a really resilient and remarkable way. And I have an entirely other talk to talk about large deformation mechanics. So I think I convinced you that the mechanical integrity of these tissues are critical for successful pregnancy. However, preterm birth rates are extremely high, particularly in this country. Preterm birth is birth before 37 weeks of gestation. 1 in 10 babies are born preterm in this country. There's a disproportionate amount of preterm birth around the country, listed here by the March of Dimes. Preterm birth is the #1 cause of neonatal death. I think that should stop us in our tracks right away. Preterm babies or preemies that survive are at risk for lifelong health complications such as cardiovascular disease. Preterm birth is associated with maternal mortality, and cost of poor American maternal health care is in the billions. And this doesn't even touch the emotional costs that those go through. So there's that 1 in 10 number, 80% of those are caused by spontaneous preterm birth. Just like the name suggests, a patient doesn't know that this is going to happen to them unless it's happened to them in a previous pregnancy. And so the 1 in 10 number, there's the 80%, there's 3 different styles. So there could be preterm labor contractions, perhaps caused by uterus overstretch. The amniotic sac can break, that is the premature rupture of the fetal membranes. And then the cervix can be too soft, and this is called cervical insufficiency. These different etiologies we're still studying. Some of them also overlap with each other. And then you can see I've underlined stretching, breaking, softness. Again, these are all engineering concepts. It was great, yesterday's conversation is why don't we talk to engineers more when we talk about health problems? Trust me, there's not many engineers in this space, so I also welcome people to join me. So what do they do in the clinical standard of care? So right now, if you're pregnant and you want to know if you're at high risk for preterm birth, it's a wait and see type of thing. You just sort of like, just if I'm a new mom, you just sort of go to your doctor. They do sonography. This is a cervical length screening. Most pregnant individuals in the United States get this screening. It's a transvaginal view. It's a sagittal view of the cervix, so you can see the cervix. And what they do is they place a one-dimensional caliper and they give you a cervical length. If your cervix is short, you're at risk for preterm birth. If your cervix is long, then you go and live your life. Again, well, one begs a question, well, this is a 2D image, why don't you take more than just a 1D caliper? Also, what is the material made out of the cervix? And then once you're placed at high risk, there are no solutions. This slide I've been giving for the last 20 years of my career, and these things have come and gone. There's progesterone, which is a hormone thought to quiet uterine contractions. A version of it came on and off the market around 2017. Some physicians will put you at bed rest, but an inflated balloon is an inflated balloon, no matter if you're standing up or laying down. That doesn't work. The pessary, which is a silicone donut that closes the cervix, it did well in Spain, but it didn't do well in a clinical trial in over 10 European countries. And then it just failed its clinical trial here in the United States. I can talk at length about the pessary. And then all we have left is a surgical cerclage. But there are complications. Lacerations can occur. The knot can become buried. The suture can migrate. And preterm birth can still happen. So the vision that I have, and I guess it's similar, we're seeing similar styles in all of these talks. It's patient-caregiver partnerships. It's tracking. It's trying to understand what is going on through a digital twin, through a visual that perhaps a patient and a caregiver can come around together and assess what is going on with this pregnancy. So ultrasound is used quite a bit in the United States. So we said, well, hey, why don't we make a digital twin based on sonography, because it's minimally invasive. Our patients love sonography. They get to see the baby. Can we create a digital twin through that? And then also, we do have to get some kind of in vivo assessment of that tissue remodeling. We work with a company in Switzerland called Pregnolia. I have no financial relationship with them. And we're also testing out, can we get something from the cervical vaginal fluid, perhaps through a tampon or a self-collection, that can give me idea of that active biology that I was talking about. So then I can then say, okay, is that cervix, is it 1 megapascals? Is it 100 kilopascals, et cetera? So we're trying to connect that biology to the structure or function of the uterus and cervix. So this is ongoing research that we have in my lab. And then can we package it up for the clinician at the bedside to have a predictive digital twin to predict, is there going to be a mechanical overloading event? Is this patient going to be at risk? And if they are, what is the appropriate mechanical support that fits that patient? Or is it not mechanical at all? So I did a couple studies. This was an NIH-funded study that I got, where I was basically like, let's build digital twins of low-risk pregnancy so I can have a library of uterus and cervices that I can build finite element simulations of. So I'll tell you about these studies. But I had to invent a new sonography protocol to get all of the dimensions that I needed. And so I'll talk about that. And so what I did was, and this is a story I like to tell, before I was pregnant, I was a young faculty member, didn't have any funding, and I wrote all these big NIH grants, and I said, I'm going to build digital twins of pregnancy using MRI, because I get these beautiful high-resolution images, and my reviewers are like, no pregnant patient is going to go into an MRI. Also, it's super expensive. When I was pregnant myself, I determined, I was like, hey, we're getting a lot of ultrasounds, and I'm seeing my doctor at all these different clinical time points. Well, why don't I just spend 5 or 10 more minutes? And then what I did was I invented a maternal anatomy scan. It's the same thing as a fetal anatomy scan, but I just spend 15 more minutes. And I teach SolidWorks, I teach graphics in my other career as a professor of mechanical engineering. And I said, hey, if I just put it in a design table, I can create an entire library of uterus and cervices, and I can have my students build them themselves. And so that's what we did. And what this unlocked and enabled for me was that I can study many, many different women at many, many time points in their pregnancy, and I can generate a lot of data this way. And this project is really, I really love this sort of idea, because it brought a whole ton of engineers studying pregnancy in my laboratory. So we invented that. I work with Sabrina Badir. I was actually on her PhD committee at ETH Zurich. She has a company where they have an aspiration device, so we can measure the mechanical properties of the cervix during pregnancy. It's done during a speculum exam. So with those two, we designed a prospective, discovery-driven clinical study. And here's the study. So I have a study called LORI, which is the low-risk cohort. These are all the physicians I had to interact with, so I had to make things simple to them. My team works very closely with them. So we looked at 50 pregnancies. We screened them for risks of preterm birth. We saw them at 4 research visits. Each patient got a cervical stiffness measurement, a maternal anatomy scan, and a swab of the cervical vaginal fluid. And then I did an ancillary project to the clinical trial of the pessary to understand, was there or is there a mechanical benefit to this device? So this was through the NIH Maternal Fetal Medicine Units Network. These patients did not have a history of preterm birth, but they presented in their current pregnancy with a short cervix. We saw them at 2 research visits. We took cervical stiffness measurements before and after pessary placement if they were in the pessary arm of the clinical trial. And then we did maternal anatomy scans. And we did this at the 2 research visits, the one at randomization, which is the visit 16 to 23 weeks, and then at a follow-up visit if they made it. So this is some of the first biomechanical data recorded for high-risk pregnancies. So let's look at some of the data. So with Lori, our low-risk cohort, we created the first pregnancy digital twin library with combined cervical stiffness measurements, maternal measurements, and also fetal measurements. And you can see here we've just published a CAD library. Oops, I don't have a pointer. Let's go back. I have a CAD model in first all the way out to term. It's of 50 pregnancies, and you can see how we build them. This is our cervical softening data. On the left-hand side, you can see this is our aspiration measurement. So the higher the closure pressure, the stiffer the cervix. What we found is that the cervix starts to soften right around the second trimester. It has to prepare itself to be very, very soft. Clinicians didn't believe me because they're like, why would the cervix soften early, right? And then I would say, well, and why doesn't it open if it softens so early? And I say, well, the mechanical load isn't there yet. Because when they think of softening or remodeling, they see it in the sonography image as a cervical length caliper shortening. But what we found in our digital twin model was like, well, no, the cervical length shortens because that's when the mechanical load appears. So this is the first of its kind data in the United States, and we were overlapping with the European data. We were excited about that. This data we're getting ready to publish, this is cervical aspiration data for those high-risk patients. We actually had to use the digital twin to understand how the aspiration device was actually engaging with really short cervices with an amniotic membrane behind it. There is a little bit of a correction factor that we have to do for that, and that's something that we're talking with Prognolia about. But what we found here is that the patients who had the softest of cervices delivered very preterm. And so let's look at some simulations. So we have now a library of personalized simulations of pregnancy. And this is the fetal membranes coming down, pressurizing, thinning the uterine wall, and driving large stresses at the cervico-uteral junction. And if we look at the proximal view of the cervix right there, we can see our traditional hoop stresses in our cervix, but we can also see these large radial stresses pulling the uterus, pulling the cervix open. Again, I don't think I needed a digital twin to do that as a trained mechanical engineer, but I think Claire said it earlier, it's about coming around the table with your clinicians who don't know continuum mechanics and saying, hey, I think we have a mechanism here of how the cervix opens. Can we image that in ultrasound? And so now we're doing those sort of hypothesis-generating studies in prospective clinical studies at Columbia. So now let's look at the library of this is my biomechanical fingerprint of the mechanical load of the cervix. On the left-hand side, we have our low-risk patients. On the right-hand side, we have our high-risk patients. And lo and behold, you can see, I don't have to go too deep into this, but on the low-risk side, they're mostly not loaded. And on the right-hand side, my high-risk cohort, I certainly had ones that were very, very soft and that mechanically failed because of a soft cervix and how maternal anatomy drives that stress concentration. But the big point I want you to take away from this slide is that patients who were considered high risk, they didn't need to be considered high risk because they had a mechanically firm cervix that could structurally stay closed. So in medical care in the United States is that we would, again, place the patients on the lower right at a high-risk category, which maybe they could be placed in a low-risk category. So this idea that we can have this mechanical fingerprint to better risk assess you for preterm birth is something that we're writing to the NIH to do a prospective validation cohort. So my time is up, so I'm going to stop there. I had an entire sort of talk about how we then use these digital twins to understand the cervical cerclage, and that's something that I can talk about in a Q&A or if you catch me in networking. So I'm going to stop there and just, yeah.
Thank you very much. It's a very exciting presentation.
Thank you.
Yeah. So maybe a few questions from the room. Yeah, we have some questions.
I saw that hand go up, yeah.
Yeah.
Hi, first of all, thank you. As an engineer, it's so nice to see so much engineering in health science. Wow, really. You talked about the material properties of the uterus and the changes that it go. I was interested in to understand if pre-birth, let's call it danger, is caused due to just the loading of the baby in a specific position, or is it material degradation over time? And can you see that in the virtual twin simulations?
Yeah, it's probably, for one patient, it could be an overloading of the uterus and the cervix because of, the external load placed on these tissues. Also, there's a lot of inflammation that causes preterm birth. So that could be a specific etiology of preterm birth. Then there could be a patient who has a my cervix is too soft etiology, and that could be because of the cervix 1. It's just too soft to begin with. Even in preconception, you just had a soft cervix. Or perhaps you had a gynecologic condition that caused you to have their surgical procedures for HPV that occur, or you can have some kind of gynecologic disease that changed the composition of the biology of your cervix, placing you just at high risk right away. Or during your pregnancy, you can have, there's hypotheses swimming around about dysbiotic microbiome, something to do with the health of the cervical vaginal fluid, and that alters the structure function of your cervix. These are all open research questions, and we would like to have specific etiologies for each patient so that we know exactly which therapeutic that we should go with.
Is there other question? Maybe, yeah, okay. Two questions.
So I saw that your research mainly focused on singleton birth, and I
Yeah.
had twins, so I'm very curious. I have real twins, not virtual twins. So very curious how you may be applying your research for multiple births.
Yeah, and actually the clinical trial for the pessary for twins is still going. It was successful. It just failed for singleton pregnancies. My simple answer is, and I don't love this answer, is I just haven't gotten to twins yet. So that is my simple answer. And when you design clinical trials, like you have to have these very strict inclusion-exclusion criteria, and they always end up in my exclusion criteria. But I would love to study twins, and I hope somebody that I train in my laboratory will start another pregnancy biomechanics lab. Because in like cardio I tease my orthopedic biomechanicians at Columbia because there's like tens of them. And then in cardio, I was like, wow, I feel so behind everybody because there's like so many of you, and there's only me. So there needs to be more people. So maybe you can study twins. Yes.
And we have a last question. Okay, it was the question. Oh, no.
Hello. First of all, fantastic work. It's really great to see all of this. I just have a very naive question here. Looking at the pregnancy, I mean, some women undergo C-section that lead to a cut of the uterus. I mean, did you look in this kind of thing? What would be the impact?
Yeah. That is actually where we're going with our digital twins, is somebody who's undergone a uterine surgery. So cesarean section scarring. In the gynecology world, and I have a whole gynecology research in fibroids, in endometriosis, a lot of those individuals have to have myomectomies where they're taking large fibroid masses out of the uterus, and the surgeon basically Frankensteins their uterus back together, and you have all of this scarring. And the main question that those patients have is, can I get pregnant? Can I carry this pregnancy out to term? Can I have a vaginal delivery, or do I need another C-section? So these are questions that we're trying to get funded in our research to ask those exact questions. So uterine scarring is right at the top of the list. Not a naive question.
Thank you very much.
Thank you.
Congratulations.